Hello, Dr. Akshada. You can just.
Okay. Thank you, Dr. Jasul. Shri Gurubhyo Namaha. A very warm good evening and welcome to one and all. And also welcome to our today's guest speaker, Dr. Fahad Basheer. On behalf of Ayurveda MAP, I welcome you all for another very interesting session, online sessions on gastrointestinal disorders and its management. Dahana, online sessions on gastrointestinal disorders and its management, organized by Ayurveda MAP. Starting from today, we have different faculties who will be speaking on different topics. These are our topics. So mainly clinical anatomy, physiology and microbiota of gastrointestinal system, introduction to common digestive disorders, gastrointestinal disorders, clinical approach and diagnostic insights, inflammatory bowel disease and its management, gastroesophageal reflux disease and its management, celiac diseases management in Ayurveda, peptic ulcer disease and Ayurvedic management, gastrointestinal motility disorders and its management, approaching patients in GI carcinoma, psychosocial aspects of digestive disorders, medicinal yogas in GI disorders, nutrition and lifestyle for digestive health. These are our topics. And the features of the online session is there are 12 live sessions. So every day it starts at 8 p.m. in the evening. And medium of communication will be English. All the videos will be recorded and the access will be available for 2 years. All the notes will be provided. There will be brainstorming discussions with faculties and queries will be answered in all the sessions. And a course certificate will be provided at the end. And post-course support to the participants will be provided. Also, printed course module will be couriered to your address. A printed course certificate will also be given. Access to exclusive Telegram group. Also, post 60 days doubt clearance support will be provided, and there will be case discussions. Also, from Ayurveda MAP, we have an offline professional diploma in integrated sports medicine in Ayurveda and advanced diploma in Ayurveda Panchakarma. These two courses are ongoing, and those who all are interested can contact Dr. Jasul, Ayurveda MAP. So coming to today's topic is clinical anatomy, physiology, and microbiota of the gastrointestinal system. And today we have our guest speaker, Dr. Fahad Basheer, who is an MBBS doctor. He has completed his PG diploma from UK, and he's a PG scholar. Little bit about our speaker, Dr. Fahad Basheer. He has completed his MBBS and PG diploma from UK, and he's currently doing his MD in physiology. He's an international author and has authored many books related to emotions, epigenetics, and gut microbiome. He's also the founder of Project Cannabis, the first integrative online platform for treatment of medical conditions with medical cannabis, which will be launched soon. I welcome you once again for today's session, sir. Over to you.
Thank you, madam, for introducing me. So today we will be discussing about gut microbiota, clinical anatomy and physiology of the gastrointestinal tract. So I will be sharing the screen. Please wait for a moment. So can you see my screen?
Yes, sir.
Okay. So shall I start?
Sure, sir.
Okay. So today we are going to discuss about clinical anatomy and physiology of the gastrointestinal tract, and the gut microbiome will be discussed in the later part. So first of all, I'll give you a small introduction that our GIT starts from the mouth or from the oral cavity and it ends in the anus. So it's a hollow vascular organ that starts from the mouth towards the anus. So beginning with the gastrointestinal tract, we will first begin with the pardon this minute, just a minute. So we will just begin with the. Can you see my slide, sir?
Yes, sir. Visible,
okay.
sir.
Okay. First, we will begin with the dentition. That is the how the teeth are arranged for the digestion. So the point is that what I'm going to say is that we will discuss about in great detail about the abdominal organs. But as we know that we know that the GIT starts from the mouth. We will have to start from the teeth, oral cavity, and pharynx, esophagus, then into stomach, then into small intestine, then into large intestine. So we will be starting from the teeth. So starting from the teeth, you can see that we have four different types of tooth. That is incisors, canine, premolar, and molar. So the incisors are the teeth that is used for biting the pieces of food. It is used to, like, if you want to eat an apple, we will generally use the incisors because we are evolutionarily wired to use vegetables to be cut with incisors, that is in the front of the teeth. Then we got canines. Canines are similar to the functions of incisors, but it is evolutionarily hardwired to cut down meats, to eat the meat. And then we got premolar tooth and molar tooth, that is for grinding and chewing of the food. So, these are the four different types of teeth that we use for the cutting, grinding, and chewing of the food. So coming after that, once after we chew the food, then the next process that takes place is the salivation. That is the mixing of the food, crushed food with the saliva. So from where does the saliva is produced? The saliva is produced from three major glands. That is parotid gland, submandibular gland, and sublingual gland. So parotid, submandibular, and sublingual gland are located in the mouth around the oral cavity, inside the muscular and bony, between the muscular and bony prominence in the mouth. So the parotid gland is a serous type of gland. It is watery in consistency. It is not viscous in nature. So parotid gland is the largest gland in the largest salivary gland in the human body. So it is a serous type and it has a watery in consistency. And then we got submandibular gland. The submandibular gland is mixed. That is, it is both serous and mucus type. As it becomes mucus, it becomes more viscous. As it becomes more serous, it becomes more watery. So that is the concept. The more the gland is serous, it is said to be watery. The more the gland is mucus, it is said to be viscous in nature. That is, viscosity will be increased. So submandibular gland is mixed. That it has a both serous and mucus consistency, mucus type. So it can be semi-viscous. That is, it is neither too watery, it is neither too viscous. Then we got a sublingual gland. The sublingual gland are purely mucus gland, mucus type of gland. So the secretion from the sublingual gland will be highly viscous. And then we got minor glands. The minor gland is also a mucus type of gland. Minor glands means the glands that are located in the pharynx and in the posterior part of the mouth. So it is of less relevance, but even though it is of less relevance, it produces the mucus type of gland, which is highly viscous in nature and is only detected in trace amount in the oral cavity. So primarily it is parotid gland, submandibular gland, and sublingual gland. The parotid gland is more watery in nature, sublingual gland is more viscous in nature, and submandibular gland is in midway between becoming both watery or viscous in nature. The functions of the salivary gland is that normally the human salivary glands produce about 0.5 to 1.5 liters of saliva daily, at least 1.5 liters. So we need at least 1.5 liters of water. That is like you can imagine like a 1 liter of Pepsi bottle. So if you imagine such a bottle in your mind, you will get an idea that about 1 liter, about 1.5 liter of saliva is being produced in the mouth, and we are not aware. It is not being or like produced in produced in excess. It is not being produced in lesser amount. So we got conditions like in which known as xerostomia, where the production of the saliva is less, and we got condition in a condition called cyanoria. The cyanoria means the cyanoria means the production of the saliva will be too much. So the function of the saliva is to aid in mastication, swallowing and speech, lubrication of oral mucosa, and to provide an aqueous medium for the taste perception. So for mastication, then that is for chewing, then for swallowing, and then for speech. If you want to make a proper conversation with two individuals, you need saliva for proper speech, and then for the lubrication of the oral cavity. And it also provides an aqueous medium for the taste perception. And they also participate in the digestion of the triglycerides and starches, that is by secretion of the lipases and amylase. For the digestion of the starch, we got salivary amylase, and for the digestion of the triglyceride or the fatty food like chips, we got lipase, salivary lipase that is produced in the saliva. But in generally, salivary amylase is much more than the salivary lipase. So here you can see the anatomical structure of the parotid gland, sublingual gland, and submandibular gland. So you can see the parotid gland on the, you can see the parotid gland over here, that is above the muscles. Okay, above the muscles of mastication, you can see the parotid gland in yellow color. And here you can see the sublingual gland that is just below the tongue. And then you got a submandibular gland that is below the mandibles. Okay, so that's the name, parotid, submandibular, sublingual. Sublingual means below the tongue, submandibular means below the mandibles. So coming to the blood supply for the parotid gland, it got an arterial supply, it has got a venous supply, and it has got a nerve supply. So arterial supply is supplied by posterior auricular and superficial temporal arteries, and venous supply is by retromandibular vein, and nerve supply consists of both sensory nerve supply and autonomic nerve supply. Sensory nerve supply is by auriculotemporal nerve and great auricular nerve. The nerve supply sensory means that it will sense the external environment of the sublingual glands or submandibular glands, parotid gland, and it is taken into the brain, and it comes down through the autonomic nerve system, that is a motor nerve system, like motor autonomic nerve system. We got parasympathetic and sympathetic branches. The parasympathetic branches, what does it do is that it will increase the secretion, and sympathetic branches will decrease the secretion. So this is in nutshell, whenever a food is placed in the tongue, it is sensed by the sensory nerve from the glands, and it sends information to the brain, and from the brain it sends down information through two paths, that is either parasympathetic or sympathetic. If the food requires more of mastication and swallowing, mixing with the saliva, it will stimulate the parasympathetic nerve system, that is cranial nerve 9, that stimulates the aortic ganglion, and that stimulates the greater auricular nerve, that will result in the increased secretion. And sympathetic nervous system, when there is no food, it is sympathetic in secretion, so it will stimulate the superior cervical ganglion to produce decreased secretion. That is, it will decrease the secretion of the saliva because there is no food, so we don't need any saliva over there. If there is food, we need more saliva. So if there is food, we need more saliva. For that, we need more parasympathetic stimulation. So these are clinical applications of the salivary gland. You can see adenolymphoma in the first figure, the figure above over here. This is an adenolymphoma. That is a tumor of the parotid gland, and it is more likely to be malignant in nature. We got two types of cancer, that is either benign or malignant. Benign means it is localized to one place, it will not spread to other place. Malignant is very volatile, it will spread to other place. So here the adenolymphoma of the salivary gland is actually a malignant tumor, and the tumor is generally removed by surgery known as parotidectomy. And then we got parotitis. In the second picture, you can see the parotitis over here. The parotitis is the inflammation of the parotid gland. Since the parotid gland is covered by a tough fibrous capsule, it will restrict the gland from swelling. But as the gland infection or inflammation occurs inside the gland, it will cause to swell up inside the tight covering of the fibrous capsule, and it will be very painful because of the stretching of the capsule. And this sensation is carried by auriculotemporal nerve to the brain. So this is an example for parotitis, infection of the parotid gland. Then we got submandibular gland. The submandibular gland is located below the mandible, and it is supplied by arterial and venous and nerve supply. So arterial supply is by submental artery, venous supply is by facial vein and sublingual vein, and nerve supply is just like what we said before. Parasympathetic stimulation increases the salivary secretion, and sympathetic fibers will decrease the salivary secretion. And then other clinical findings, clinical applied aspect of the salivary duct is that there can be stone, like renal stone, renal colic, urinary colic. There can be colic inside the salivary duct, or a duct, or a stone that is obstructing the secretion of the salivary glands. So such a ductal obstruction is known as cyalolith, which blocks the submandibular duct and prevent the saliva being produced from the salivary gland to be released into the outside world, that is to the mouth. So whenever there is an obstruction by calculi, the salivary production increases and it will get filled in the salivary gland. It will never go out and it will get infected, and it can become abscess formation can also take place. So here below you can see two arrows over here. You can see two arrows over here. These two arrows indicates there is a duct. There is ductal obstruction over there. You can see there is absence of the white color. This white color is that we injected dye known as we injected contrast medium through the salivary duct, and then we will take an X-ray and we will look for the how much it has been filled. If there is an obstruction over here, you can see the absence of the white continuity, and you can see black colors. So this black colors indicates the presence of the cyalolith, which obstruct the outflow of the saliva from the salivary gland to the mouth. And next comes the sublingual gland. The sublingual gland is supplied by has got arterial supply, venous supply, nerve supply. And the arterial supply is by sublingual and submental artery, and venous supply is by submental and sublingual vein. And we got nerve supply just like other glands, like it has got parasympathetic and sympathetic glands. The parasympathetic by cranial nerve 5 and cranial nerve 7. So parasympathetic activation will increase the salivation, and sympathetic stimulation will decrease the salivary secretion. So here you can see in the sublingual gland, you can see a swelling just below the tongue. You can see a swelling just below the tongue here over here. This is called ranula. It's a type of mucocele or mucus cyst. We know the sublingual gland is mucus in nature. So whenever the duct is obstructed, the mucus inside the salivary gland get enlarged. It will increase production, and it can lead to ranula, a condition known as ranula, a swelling that is occurring due to high mucin concentration in the base of the floor of the mouth. Next, we will discuss about the pharynx. We have discussed about the teeth and oral cavity. Now we got pharynx. You can see the pharynx is divided into nasopharynx, oropharynx, and laryngopharynx. So this is the yellow color over here is the nasopharynx. It is the nasal connection between the nasal cavity and the pharynx. Then you got the oropharynx, that is a connection between the oral cavity with the pharynx. And then you got the laryngopharynx, that is a connection between the larynx and the pharyngeal region. So this is called laryngopharynx. So there are nerve supply and arterial supply and venous supply for this pharynx region. The sensory supply is cranial nerve 9, and motor supply is by cranial nerve 10, that is a vagus nerve. And it has got an arterial supply. Arterial supply is via from the branches of the external carotid artery. There are few branches that project into the from the external carotid artery. Few branches project into the pharynx, like ascending pharyngeal artery, branches of the facial artery, and branches of the lingual and maxillary artery. And then we got venous drainage, and the venous drainage is achieved by pharyngeal venous plexus, which drains the blood from the pharynx into the internal jugular vein. So the blood supply to the pharynx come from the external carotid artery, and the venous drainage from the pharynx go into the internal jugular vein. So, like in the pharynx, we got physiology of swallowing. So we have to study about how the food is being swallowed physiologically. So we got three phases, that is oral phase, pharyngeal phase, and esophageal phase. Oral phase is that when you keep the food in the mouth, and pharyngeal phase is that when we keep when the food enters the pharynx, and esophageal phase is when the food escapes from the pharynx and get inside into the esophagus. That's why we got three phases, that is oral phase, pharyngeal phase, and esophageal phase. So the oral phase is generally under conscious control. It can be interrupted and it can be influenced and it can be suppressed at will because the food is inside the mouth. But once it is inside the pharynx, it cannot be interrupted. So in the pharyngeal phase, it cannot be interrupted. It is, but can be influenced to some degree if we try to put a finger and stimulate the pharynx, we can vomit the food out. Okay, but but it is very difficult to handle the food once it gets into the pharynx because once it gets in the pharynx, it is the autonomic nervous system and the local nerves that take part. They take take the activity of the function of the digestion of the food particles. Once it enters the esophagus, it can never be interrupted. It can be never be influenced. It cannot be suppressed. Okay, even if we do the pharyngeal stimulation, there is up to a certain limit we can pull the food out. But once it enters into the opens in the esophagus and get into the stomach, it is very difficult to get the food out. So we got three phases. That is a oral phase, pharyngeal phase, and esophageal phase of the deglutition. Deglutition is otherwise known as swallowing. So coming to the esophagus, and now we finished the pharynx. So esophagus is a fibromuscular tube approximately 25 centimeter length that transports food from the pharynx into the stomach. And it originates at the inferior border of the cricoid cartilage, that is C6, and extends up to the cardiac orifice up to the T11. That is thoracic vertebrae. T11 means thoracic vertebrae. 11th thoracic vertebrae. C6 means the sixth cervical vertebrae. So it starts from the sixth esophagus starts from the sixth cervical vertebrae and ends in the 11th thoracic vertebrae. So the esophagus, as I said, it starts from the level 6 and it descends downwards into the superior mediastinum of the thorax, positioned between trachea and vertebral bodies. So when the esophagus is generally located just behind the trachea. Okay, and I think it is located just behind the trachea. And once it reaches the abdominal cavity, the esophagus opens into the stomach at T11. So here is the graphical representation, pictorial representation of the anatomy of the esophagus. Here is the pharynx, here is the cricopharyngeus. This is the C6 level. This is the sixth cervical vertebra. From there, we got esophagus that is extending up to the T11, up to the cardiac orifice. T11 is the 11th thoracic vertebrae. So here we got the pharyngoesophageal junction, and this is the cervical part up to 4 centimeter, and we got a thoracic part up to 20 centimeter, and then we got an abdominal part that is about 1 to 2 centimeter. So we got a cervical part, thoracic part, and abdominal part, total of 25 centimeter, extending from 6 cervical vertebra into the 11th thoracic vertebra. So this is the anatomy of the esophagus. So coming to the cross section of the esophagus. So when we cut down the esophagus in two parts, and we look at the when we look down over there, you will see there are 4 layers surrounding the esophagus. There is tunica adventitia, there is adventitia, muscular layer, submucosa, and mucosa. So adventitia is the layer of outer connective tissues that is very thick in nature. It is covered of serosa, and then we got a muscle layer consists of external longitudinal layer and internal circular layer. We got an external longitudinal layer and internal circular layer. So this make it the most thickest part of the esophagus. Then we got submucosa, and then we got a mucosa. So you can see over here, we got a adventitia, which is covering of serous covering. Then we got muscular layer consists of outer longitudinal and inner circular muscles, and then we got submucosa covering the muscular layer. Then we got mucosa layer that is covering the submucosa. So coming to the esophagus has got 2 sphincters, upper esophageal sphincter and lower esophageal sphincter. So the upper esophageal sphincter is purely anatomical in nature, and it is that sphincter is controlled by cricopharyngeal muscles. So whether the food once we eat and go into pharynx, whether it has to go into the esophagus or not, is determined by the constriction or the relaxation of the cricopharynx. If it is cricopharynx is constricted, food will never enter the esophagus. If the cricopharynx is relaxed, the food will enter the esophagus. And then we got the lower esophageal sphincter. The lower esophageal sphincter is located at the junction between stomach and esophagus, and gastroesophageal junction is situated to the left of 11th thoracic vertebra. So it is a Lower, it is a lower esophageal sphincter is a junction that is found at the junction of the stomach and esophagus. So, like any other organs, it has got arterial supply and venous supply, and it has also got nerve supply. So, the arterial supply from the thoracic part of the uh, thoracic part, just esophagus has got a thoracic part and abdominal part. Thoracic part of the esophagus is supplied by the thoracic aorta and inferior thyroid artery, and the abdominal part of the esophagus is supplied by left gastric artery. And the venous supply, there is venous drainage from the thoracic part of the esophagus is carried out by azygous vein, and the venous drainage of the abdominal part of the esophagus is carried out by the water circulation via left gastric vein. And then we got nerve supply. So the upper esophageal sphincter and upper striated muscles is supplied by the fibers originating from the nucleus umbilicus. That is primarily supplied by the vagus nerve. And the fibers of the lower esophageal sphincter is supplied by the dorsal motor nucleus. So basically, both the vagus, upper esophagus and lower esophagus is supplied by the nerve, vagus nerve or the 10th nerve. And then we got the lymphatic drainage of the esophagus. We got superior, we will divide the esophagus into three parts: superior third, middle third, and inferior third, lower third. Superior third is drainage of the lymph from the upper third is carried out to deep cervical lymph nodes. Middle third is carried out to superior and posterior mediastinal lymph node, and lower third is carried out by the left gastric and celiac nodes. So function of esophagus is that it is involved in the transport of the food, and it has a protection against the reflux. Once the food enters, it should not go. The food enters the stomach; it should not come up into the mouth. So to prevent that, we have got a lower esophageal sphincter. It contracts tightly, so it prevents the regurgitation of the food from the stomach into the esophagus. And then for the coordination, esophagus works in coordination with other organs of digestive system, and it helps in swallowing. Primarily, swallowing happens in the in the pharynx, but once it also helps in the esophagus also help in the movement of the food from the pharynx towards the stomach. So there are two types of peristalsis. Peristalsis means the movement of the food by the contraction of the muscular layer of the hollow gut particle, because of the stimulation of the enteric nervous system. So whenever we got two types of peristalsis, one is primary peristalsis and secondary peristalsis. The primary peristalsis is triggered by swallowing. Whenever we keep the food inside the mouth, it will and reaches the pharynx, it will trigger the local neurons over there, and the central nervous system will be involved in the helping in the swallowing of the food, and it moves the food towards the stomach. And then in the esophagus, whenever the food reaches the esophagus, it stimulates the local enteric nervous system, not the central nervous system. For the swallowing part, for the pharynx, we need central nervous system, that is called primary peristalsis. But once the food enters the esophagus, it is stimulated by the enteric nervous system, and this is stimulated esophagus. It is stimulated by the enteric nervous system, and it's called the secondary peristalsis, which help in the clearing of the food from the esophagus and pushing the food towards the abdomen. So coming to the clinical part or the applied aspect of the esophagus. So people can have esophageal dysphagia, that is like inability to difficulty in swallowing. Some people can have difficulty in swallowing for solid food or solid and liquid food, both. If it is only for solid food, it is probably the cause is structural. It can be either intermittent or progressive. Progressive means as the diseases progress, the dysphagia become more progressive in nature. Yes, intermittent means not, it is non-progressive. Sometimes you will have, sometimes you don't have difficulty in swallowing. Sometimes you will have difficulty in swallowing. Again, you will not have difficulty in swallowing. So non-progressive can be caused due to ring or web. Ring or web means a structural thing that covers the surrounds the esophagus, and this surrounding of the esophagus will obstruct the outflow of the food from one part of from proximal esophagus to the distal esophagus. And then we got progressive esophageal dysphagia. It can be either slow, slow progressive, or it can be rapid progressive. If it is slow progressive in nature, it is due to stricture. Stricture means that whenever there is an injury to the esophagus, it will heal. Whenever it heals, it will lose the elastic ability. And if you got 25 centimeter wide radius, the radius will once you get a structure, the radius will reduce into about 10 centimeters. So that it will not, it will not be, it will also lose the ability to lose the ability or property of the elasticity. So it cannot actually increase in size. So the area is decreased, and the you will get stricture, and you will get difficulty in swallowing. And then if the swallowing, if the I mean, if the esophageal dysphagia is of rapid onset, and it is there is also accompanied by weight loss, it can be due to esophageal carcinoma. And then coming to the other thing is that if we have like esophageal dysphagia for both solids and liquid, and it is primarily caused due to dysmotility, and you can have either pain or irritation. If the pain is less and the irritation is more, it is said to be said to be achalasia. Achalasia cardia is a condition in which the lower esophageal tone of the esophagus is very high. So what happens is that lower esophageal tone is very less. So what happens is that the food will come out very from the stomach to the esophagus very fast. So whenever there is a spasm, that is, the food won't come out very fast, but there is a very nut cracking pain in the chest, just like cardiac attack. You will get pain inside this chest, lower part of the chest. So people will confuse it with the cardiac, whether it is cardiac arrest, and they will go for a checkup with the ECG, but the ECG will be normal. So ECG will be normal, and there will be severe pain, and that is due to spasm of the esophagus. So coming next to the stomach has four parts, that is cardia, fundus, body, and pylorus. You see the picture, you can see here, you can see the cardia over here, and this is the fundus, is the uppermost part of the stomach. And then you got the body, and then you got a pylorus part, that is the lowermost part of the stomach. So this is the greater curvature, and this is the lesser curvature. Okay, this is the lesser curvature, this is the greater curvature. So greater curvature, I said about the greater curvature and lesser curvature earlier. So this is the greater curvature. You can see the greater curvature over here, and this is the lesser curvature. So just as sphincters, there are sphincters for other abdominal organs. There is also sphincters in the stomach. That is the inferior esophageal sphincter in the uppermost part of the stomach, and then we got pyloric sphincter in the lowermost part of the stomach. So you got a pyloric sphincter over here. You got an esophageal sphincter over here. So whenever there is an esophageal sphincter, what does it do? When it contracts, it will prevent the backflow of the food from the stomach to the intestine. Whenever there is a contraction of the pylorus, it will prevent the outflow of the food from the stomach into the duodenum. So both the esophageal sphincter and the lower esophageal sphincter and the pyloric sphincter will be contracted when the stomach is intending to burn the food out by digestion and absorption. So similar like other organs, we got stomach has got arterial supply, venous supply, and nerve supply. So the arterial supply of the stomach is that it has got a right gastric artery and left gastric artery, right gastroamental branches, and we got left gastroamental branches. And then we got venous supply, and the venous supply is supplied by the hepatoportal vein, right and left gastric vein, that left gastric vein that drains blood from the stomach and moves the blood into the hepatic portal vein. And then we got nerve supply, that is parasympathetic nerve supply and sympathetic nerve supply. The parasympathetic nerve supply is supplied by the vagus nerve, and the sympathetic nerve supply is supplied by the sympathetic nerve fibers that arises from T6 to T9. So the general rule, if we know that in the stomach, is that whenever there is a stimulation of the parasympathetic nerve system, it will always increase the secretion, and it will always increase the motility, and it will inhibit the sphincters in the GIT. That is the general rule. And whenever there is a sympathetic nerve system activation, it will decrease the secretion, decrease the motility, and increase the tone of the sphincters. So if you know the basic concept, it will be very easy for you. That is of what the function of the sympathetic nerve system and what is the function of the parasympathetic nervous system in the abdominal cavity, you will get an idea of how the entire GIT works. So whenever the parasympathetic nervous system is stimulated, it will increase the motility. Whenever the sympathetic nervous system is stimulated, it will decrease the motility. So how the stomach acid is being produced is what is depicted in this picture. So you can see that like the acid in the stomach is produced by a certain kind of cells known as parietal cells, and this is the here is the parietal cell, and the parietal cell has gotten as hydrogen potassium pump over here. It is a proton potassium pump over here, proton potassium ATPase pump. So whenever it is stimulated by external factors, the HCl, the hydrogen, wait a minute, the hydrogen and the chloride is been secreted into the hydrogen and chloride is secreted into the stomach and form HCl, and bicarbonate and H plus has been absorbed from the stomach into the abdominal into the blood. So whenever we take a food, there will be an alkaline tide. Alkaline tide means that our blood will become more alkaline once we take food, because once we take the food, the HCl is being secreted from stomach into the abdominal cavity into the stomach, and in return bicarbonate is being pushed into the bicarbonate is being pushed into the blood vessels. So our blood become more alkaline when once the food reaches the stomach. So the secretion HCl can be stimulated by different conditions. One of is parasympathetic nervous system. Most predominant nerve of the parasympathetic nervous system in the abdominal cavity is the vagus nerve. So whenever the vagus nerve is stimulated, it releases acetylcholine, and this acetylcholine, what it does, it stimulates the acetylcholine receptors over here, muscarinic receptors, and it will increase the secretion of the HCl. And then we got endochromaffin-like cells. Endochromaffin-like cells also secrete histamine. Histamine also act on the histamine receptors, and will also increase HCl. And we got gastrin, which is produced from the G cells in the antrum, and the G cells produce gastrin, and gastrin binds with the G receptors that will cause the increased secretion of the acid secretion. And like we said in the degradation, there are different phases of swallowing. That is cephalic, that is oral, pharyngeal, and esophageal. Similar to that, we got phases of gastric secretion in the stomach. That is cephalic phase, gastric phase, and intestinal phase. So the cephalic phase is initiated by the sensory experience of seeing and eating food. So whenever we see someone is eating food, or when we see a picture of burger or shawarma, what happens is that the stomach will start to produce acid just by seeing it or just by thinking about it. So that will contribute about 20% of the acid secretion. Okay, it is caused due to the activation of the vagus nerve by the stimulation of the psyche. The psyche is stimulated by the external environment. And then we got the gastric phase. It is only initiated when the food enters into the stomach, and there will be once it enters the stomach, about 70% of the total acid secretion is being initiated, and it is also like initiated by the vagus nerve or the parasympathetic nervous system. And then we got the intestinal nervous system. Once the gastric phase is over, it enters into the duodenum. At that time, remaining 10% of the total acid secretion takes place. In some, both 20% from cephalic phase, 70% from gastric phase, and 10% from the intestinal phase totally constitute about 100% of the gastric acid secretion. So, what are the factors that inhibit the gastric acid secretion? Is that like enzymes, hormones like somatostatin, that is produced from the pancreas, and gastrin inhibitory peptide, and other like increased mucus production in the stomach will all cause decreased acid secretion in the it will inhibit the acid action of the acid in the stomach. So this coming to disorders of the stomach. So we have got different disorders of the stomach. So first one we will discuss is the gastric esophageal reflux disorder. So gastric esophageal reflux disorder, many of you will be familiar with. The gastric esophageal reflux disorder is due to it is due to the reflux of the food from the stomach into the esophagus. Here, normally the sphincter is closed, but whenever the sphincter is weak, it is failed to maintain the tone of the lower esophageal sphincter, the food will move from the stomach into the intestine, and this can cause dyspepsia, dysphagia, and sour taste in the mouth. The other condition is hiatus hernia. So hiatus hernia is that whenever the uppermost portion of the stomach is being normally the diaphragm separates the esophagus from the stomach, but whenever there is an when the diaphragmatic walls are weak, the part of the stomach will also will like hernia. It will herniate to the upper into the thoracic cavity. So it will lead to two types of hernia, that is sliding hernia and rolling hernia. So you can see the difference here. In the sliding hernia, a portion of the upper part of the stomach is being herniated out. And in the rolling hernia, you can see the upper part of the stomach herniated as a pouch parallel to the esophagus. Okay. So these are the condition which causes the hernia. So next we will discuss about the basic electrical rhythm. So just like the heart has an SA node, we all know that the heart has an SA node and it has an intrinsic pacemaker activity. So this intrinsic pacemaker activity is also there in the stomach. And that is called basal electric rhythm. And that is initiated by interstitial cells of Kajal. In heart it is SA node, but in the stomach it is interstitial cells of Kajal. It is located between the longitudinal and circular muscles, and it is absent in the proximal stomach and the upper esophagus, but is present in the lower part of the stomach and small intestine and the colon. Okay. So this is the pacemaker region or the interstitial cells of Kajal which is located. It will generate the impulses like this. You can see these impulses. Why it generates impulses? Then once this electrical impulse is generated, it will cause the contraction of the stomach. So the contraction of stomach is essentially for churning out or mixing of the food. So the mixing of the food is generated by the muscular activity, and the muscular activity is generated by the electrical activity, and the electrical activity is generated by the pacemaker region or the interstitial cells of Kajal in the stomach. So the pacemaker, the electrical waves are of two types, that is slow wave and spike potential. The slow wave means that there is a slow up and down waves that is produced in the stomach, but it will never cause any contraction of the stomach. But there will be a small upper and lower amplitude of waves that will cause a stomach to have a tone, but doesn't cause any strong contraction. You will have a resting tone. Okay. But once the spike potential, once it is stretched, or once it is stimulated by the vagus nerve, or stimulated by the parasympathetic nerve system, or stimulated by CCK or gastric, there will be an influx of the calcium and sodium into the stomach cells, and that will cause the increased contraction of the stomach to push the food from the stomach to the outside. Okay, and then there can be repolarization whenever it is stimulated by the sympathetic nerve system by the release of epinephrine or norepinephrine. It will causes the repolarization of the it will causes the potassium ions from the stomach cells to move out, so the stomachs become more relaxed and will stop the contraction relaxation. So you got a depolarization and a repolarization. Depolarization is activated by the parasympathetic nerve system. Repolarization is activated by the sympathetic nerve system. Whenever the repolarization happens, the contraction of the muscles of the stomach happens and mixing of the food happens. Whenever there is a repolarization, the contraction and mixing will be stopped. So here you can see the graph. So here you can see this is a slow wave. It will not cause any contraction. These are the slow waves. It will never cause any contraction. But these are the spike waves. You can see the spikes. These spike waves are the waves that cause the contraction of the muscles. So this is the spike waves. You can see the spike waves over here. It is stimulated by stress, acetylcholine, and parasympathetic nerve system. And then you got hyperpolarization. It is just below the even below the resting membrane potential. This is the resting state. This is the contracted state. This is above the resting state. And then you got hyperpolarization that is below the resting state, stimulated by the norepinephrine and sympathetic nerve system activation. Now coming to the liver and gallbladder and pancreas. So you can see the liver over there in the red color, and you can see pancreas, and you can see a green color gallbladder. Okay. So coming to the liver has got two surfaces, that is diaphragmatic surface and visceral surface. Diaphragmatic surface or the surface that is the anterior superior part of the liver that is in contact with the diaphragm. And the visceral surface is the lower part of the esophagus, lower part of the liver that is in contact with the visceral organs of the abdominal cavity. So liver has got different lobes. So it is primarily covered by a capsule known as Glissen's capsule. It has got a right lobe and a left lobe. Okay. And it has got accessory lobes like caudate lobe and quadrate lobe. So this is the superior surface. You can see the inferior surface. Superior surface is the diaphragmatic part. It is in contact with the diaphragmatic part. So inferior surface is contacted with the abdominal organs. So there are different ligaments that are attached to the liver. There are falciform ligament, coronary ligament, and triangular ligament. So these are the three ligaments that is attached to the liver. And whenever we take a cross section of the liver, when we cut the liver, and when we look inside the microscope, you can see a portal triad inside it. Inside the portal triad, there will be an arteriole, there will be a venule, and there will be a bile duct. So I will show the picture over here. This is the picture. So whenever we take the liver, you cut the liver, take the cells, take a tissue of the liver, and then we keep in the microscope. You can see the cells of the liver in hexagonal shape, cells of liver. Within the hexagonal shape, you can see a star shape, starfish-like structure. In the center of the starfish, you can see a portal triad. That is the portal triad. So in the portal triad, this is the portal triad, and in the periphery of the portal triad, you can see the portal vein, portal artery, and the bile duct. Okay, and this is the central vein. This is the portal triad. Okay, this is the portal triad. So the liver is supplied by hepatic artery and hepatic portal, and is drained by the hepatic portal vein. And the nerve supply is of the liver is supplied is innervated by the hepatic plexus, which contains both sympathetic and parasympathetic plexus of nerves. So coming to the function of liver, the liver has many functions physiologically. First, we will discuss about detoxification. Detoxification is the detoxification of the drugs and alcohol. It has to remove the harmful effects of the drugs that we take, harmful effects of the alcohol that we take. And it will also remove the unwanted fatty acids and steroid hormones. And it will prevent it will convert the ammonia. Ammonia is very harmful to the body, so it is converted into urea. Hormone are two types, T3 and T4. So conversion of T4 to T3 takes place in the liver. And then, can you hear me? Hello? Hello?
Hello, sir.
Can you hear me?
Yes, we can hear you.
Okay. So, then the other thing is that it is also involved in the protein synthesis. So the protein synthesis for blood clotting and cholesterol transport in immune functions like of the globulins and maintaining oncotic pressure like because of albumin and maintenance of copper levels by ceruloplasmin. So the ceruloplasmin, albumin, globulin, lipoproteins, and prothrombin are all produced from the liver. So the liver maintains control of the blood clotting, cholesterol transport, immune functioning, oncotic pressure, maintaining oncotic pressure, and maintaining the copper level. We need the proper functioning of the liver. And then it is also involved in the production of the bile. So the production of the bile is also done by the liver and the gallbladder. And liver also plays an important role in the storage of glycogen. Glycogen means that once the glucose is taken into the liver, it is stored in the liver as structure known as glycogen. So has a function of storing the glucose in the form of glycogen in the cell liver. And it also stores other micronutrients like copper, zinc, magnesium, iron, vitamin A, vitamin D, E, K, and B12. And it is also involved in the formation of precursors of the cholesterol. Like precursor of it is also involved in the formation of the vitamin D. So this is the basic laboratory test that we do for patients with if we suspect any jaundice or if we suspect any liver diseases, we will do a LFT, liver function test. So in the liver function test, you can see that I will teach you about this in detail in the next slide. So you will see the bilirubin total level is about 0 to 1 milligram per deciliter. Conjugated bilirubin, you got unconjugated bilirubin. Conjugated bilirubin is the bilirubin that is conjugated with glucuronic acid. Unconjugated bilirubin is the bilirubin that is not conjugated with glucuronic acid. And then you got SGOT. SGOT will be high in alcoholic patient. So if you get a patient, if the patient is having high levels of SGOT, you must suspect the patient is is a heavy drinker and is an alcoholic abuser. And then you got, if the SGPT levels is high, it means the patient is having viral hepatitis. And if the alkaline phosphatase level is very high, it means the duct, the common hepatic duct, the duct which drains the liver, the biles from the liver to the that drains the bile from the liver to the stomach to the intestine, duodenum is been blocked. If that is blocked, alkaline phosphatase will be high. Then you can see the total protein level, okay, and you can see albumin level and globulin level. If the albumin level will be very low when you got renal failure or liver failure. Renal failure, when the renal failure happens, the albumin will be lost in the urine, so the albumin level will be low in the blood. And even if the liver is damaged, the albumin production and the globulin production will be lost. So how the bilirubin is being produced in the blood is the other question. So whenever the blood RBC, whenever the lifespan of the RBC is generally 120 days. When the 120 days is over, the RBC is going to die anyway. So also by other external causes, the RBC can lyse, like hemolytic diseases. So RBC, once it is degraded, it degrades into heme, and heme is converted to unconjugated bilirubin. This is the unconjugated bilirubin, and unconjugated bilirubin is then taken into blood through to the liver by albumin. Albumin is produced from the liver, and once it leaves the liver, it is conjugated with the glucuronic acid. You can see the enzyme, uridine glucuronide transferase is the enzyme that it conjugates the bilirubin with the glucuronides and forms the conjugated bilirubin. Once the conjugated bilirubin is formed in the liver, it is released into the gut through the duodenum. Okay, to the duodenum, and from there it reaches the small intestine, and the gut bacteria converts the conjugated bilirubin into urobilinogen. And 80% of the urobilinogen is secreted in the feces, known as stercobilin, and 2% of the urobilinogen is secreted in the urine, known as urobilin, and 18% of the urobilinogen is been again taken back into the liver for conjugation. It is a recycling process. So it will preserve 80% of the urobilinogen been taken back into the liver. Remaining 80 to 82% is being secreted out through the feces and urine. So jaundice are of 3 types. We got prehepatic jaundice, intrahepatic jaundice, and posthepatic jaundice. Prehepatic jaundice means whenever there is a damage to the RBC membrane, or whenever the RBC is damaged before reaching the liver, it can lead to jaundice, and that is called prehepatic jaundice. And once it reaches the liver, so in the prehepatic jaundice, the unconjugated bilirubin will be very high. In the hepatic jaundice, once there's a damage to the liver, the proper conjugation of the bilirubin will not take place. So that will lead to decreased conjugation. As a result, unconjugated and conjugated bilirubin will be high. So in the post-hepatic jaundice, whenever there is obstruction in the bile duct, in the common hepatic duct, it can lead to conjugated hyperbilirubinemia. Conjugated blood will be high. So the thing is that once the hemoglobin is in the blood, it is said to be unconjugated bilirubin. Once the hemoglobin enters once the bilirubin enters the liver, it is said to be conjugated bilirubin. And once it is released to the intestine, it is said to be conjugated bilirubin itself. So whenever there is a lesion above the liver, it is said to be unconjugated hyperbilirubinemia will be increased. UCB will be high. Whenever it is in the liver, UCB and CB will be high. That is unconjugated bilirubinemia and conjugated bilirubinemia will be high. And whenever it is in the obstructive state, post-hepatic state, the conjugated bilirubin will be high. So this is how we will assess the whether the patient is having prehepatic, hepatic, or post-hepatic jaundice. If it is prehepatic, it can be due to hemolysis like G6PD deficiency or cirrhosis. If it is intrahepatic, it can be due to hepatitis or cirrhosis of liver or congestive hepatopathy or tumors of livers. If it is post-hepatic, it can be due to polydoccolithiosis or primary sclerosing cholangitis, that is inflammation of the bile duct. So by taking LFT, we will look whether the unconjugated is high. or whether unconjugated or conjugated high, or whether the conjugated high. If it is unconjugated high, it is prehepatic. If unconjugated conjugated high, it is hepatic. And if the conjugated is high, it is post-hepatic. So if for each prehepatic, hepatic, and post-hepatic conditions, there can be other causes. So this is how we will diagnose the diseases. So in the gallbladder, coming to the next part, that is gallbladder is a tiny organ, a sac-like organ that is found just below the liver, and it has got a fundus, body, and neck. And you can see the fundus over here, and you can see the body, and you can see the neck, and this is the cystic duct, and this is the intrahepatic duct. So intrahepatic duct comes from the liver, and cystic duct comes from the gallbladder. Both combine to form common bile ducts. Okay. Now, once here the common bile duct comes over here, it binds with the pancreatic duct over here, and then it forms the ampulla of water over here. Ampulla. This is the ampulla, means the swelling, swelling of ampulla of water. Okay, so the cystic duct joins with the common hepatic duct, and then it forms the common bile duct, and common bile duct combines with the pancreatic duct to form the hepatopancreatic duct or the ampulla of water. So the arterial supply of the gallbladder is by cystic artery, venous supply is by cystic vein, and nerve supply is by the celiac plexus or the vagus nerve. Functions of the gallbladder is for the storage of bile and release of the bile and regulation of the bile flow and regulate the bile pH and help in the absorption of the vitamins, especially the fat soluble vitamins. That is vitamin A, B, E, K. A, D, E, K are the fat soluble vitamins. For the absorption of the A, D, E, K, we need bile. So the bile is produced from the gallbladder. So gallbladder also have certain diseases. So there can be cholelithiasis, it can be biliary colic, it can be cholecystitis, choledocholitis, cholangitis. So cholelithiasis means uncomplicated gallstone. That is, whenever the gallstone is in the cystic duct, non-cystic duct, whenever it is in the gallbladder, it doesn't harm. It will never harm the patient. That is called cholelithiasis. And biliary colic is that whenever the stone comes through the biliary tract, it will obstruct the tract and it is known as biliary colic. And cholecystitis means whenever there is inflammation of the gallbladder, it is known as cholecystitis. And then we got choledocholithiasis, that is when the gallstone is in the common bile duct, it is called choledocholithiasis. And cholangitis means the infection of the entire biliary tree. So here you can see if the stone is in the gallbladder, it will never cause a problem to the patient. This is known as the gallbladder stone or the cholecystolithiasis. So whenever there is a whenever the stone comes in the common bile duct, it will cause choledocholithiasis. This will cause the obstruction. This will be a problem because it will cause obstruction to the bile flow from the liver and the gallbladder to the intestine. So it will cause the inflammation and swelling of the gallbladder over here, and it will cause it can cause cholangitis. That is the infection of the biliary tree. So this is the gallstones. You can see the yellow colored gallstones over. So next, coming to the pancreas is an organ that is both endocrine and exocrine in nature. Endocrine means that it produces the hormones like insulin, somatostatin, glucagon for controlling the blood glucose levels. And then you got exocrine glands that secrete pancreatic amylase and pancreatic lipids that help in the digestion of the food. And the pancreas consists of a head, uncinate process, neck, body, and tail. So here you can see this is the uncinate process, this is the head, and this is the neck, and this is the body, and this is the tail. It is seen very close to the duodenum, and it's a retroperitoneal organ. It is covered by the peritoneum. So this is the anatomy of the pancreatic duct. So it starts from the pancreatic tail and it goes and projects into the duodenum through the sphincter of body. Okay. So as like other organs, just also got artery supply, venous supply, and lymphatic drainage. Artery supply is by splenic artery, venous supply is by hepatic portal vein. Branches of mesenteric branches of the hepatic portal vein. And the lymphatic drainage is drained into pancreatic splenal lymph nodes. And the function of the pancreas, it is both exocrine and endocrine. So this is the you can see this is an endocrine function of the intestine of the pancreas. The alpha cell secretes the glucagon, and beta cells secretes the insulin, and gamma cell secretes the pancreatic polypeptide, and delta cell secrete somatostatin. Glucagon, what it does is that it will increase the glucose level, and insulin, what it does is that it will decrease the glucose level. And pancreatic polypeptide has unknown functions, and somatostatin, pancreatic somatostatin is a function that inhibits the growth hormone. Okay, so you can see over here the function of the each hormone that is produced by the insulin. So there are conditions that can lead to pancreatitis. Suppose a patient comes with heavy abdominal pain, severe abdominal pain, and this get worsens on eating food, and such patient can have pancreatitis. So we will send for a USG, and when the USG report comes, you can see that the patient is having pancreatitis. So the pancreatitis can be caused due to different conditions. It's most commonly in India, it is due to alcohol. Okay, and in pregnant women, it is due to gallstones. So gall gets smashed is a mnemonic for the causes for the pancreatitis. So G for gallstone, E for ethanol, T for traumas, S for steroids, M for mumps, A for autoimmune disorders, S for scorpion stings, and H for hypertriglyceridemia, hypercalcemia, hyperparathyroidism. ERCP means it is an endoscopic procedure that is used for checking out whether there's a problem in the pancreas. Even if you do that procedure, it will also likely to get the pancreatitis. And certain drugs like sodium alkaline given for the epilepsy, azathioprine and sulfonamides given for certain other conditions can also cause pancreatitis. So these are the conditions that probably most commonly causes the pancreatitis. Now coming to small intestine, the small intestine has got we divided into duodenum, jejunum, and ileum. And the duodenum is divided again further into 4 parts, that is D1, D2, D3, D4. And D1 is the superior, that is spinal at the level of spinal level 1. And then D2 is descending from L1 to L3, and then D3 at the inferior L3, then D4, that is L3 to L2. So we got a superior part of the superior part, then we got a descending part, that is a D2, then we got the inferior part, that is a D3, and we got the D4, that is ascending part. So these are the 4 parts of the duodenum. And duodenum is the area where this bile duct, pancreatic duct, and this common duct all comes and secrete their secretions. Okay, then comes the jejunum and ileum. Jejunum and ileum are attached to the. It is held on to the abdominal in the abdominal cavity by the mesentery. Okay, so it's like if you imagine just like a curtain, and the curtain has got some particles that is hanging around below it. And the particles that the curtain is known as mesentery, and the particles that hang below the curtain is like jejunum and ileum. So that's how the stomach, small intestine, is been floating in the. It is held in the abdominal cavity. Okay. So like duodenum also have blood supply, and the proximal to the major duodenal papilla is separated by the gastroduodenal artery, and distal to the major duodenal papilla is separated by the pancreatoduodenal artery, and like it also have venous supply. And jejunum and ileum has artery supply by the superior mesenteric artery, and the venous supply is by superior mesenteric vein. And the function of the intestine is that it helps in the digestion, absorption, elimination, and maintenance of the alkaline balance. For digestion of the stomach, whenever there is a food in the intestine, it will be digested out. It will be crunched from high carbohydrates into small molecules, small small amino acids or small carbohydrates like glucose. For carbohydrate to glucose, it will convert carbohydrate to glucose. It will convert proteins to amino acid, and it will convert the fatty acids to the triglycerides, small chain fatty acids, and it will also play an important role in the elimination. That is the elimination of the elimination of the food bacteria and toxins, and it also helps in maintaining the electrolyte balance, and that is absorption of the sodium and potassium is also maintained by the uh, small intestine. So coming to the small intestine, there are certain things that we have to know. So the intestine has also have its own brain. So when someone asks you like whether there is a second brain in the human body, we will say that the GIT is a second brain. Even the heart also have a form of brain that can work independently of the brain. And similarly, but in the modern science, GIT is the most extensively researched because it has got a huge number of neurons, just like that of brain, than the heart. So that's why the enteric nervous system is also called as the second brain of the uh, human body. And the enteric nervous system is of two types, that is called meandric orbic plexus and Meissner's submucosal plexus. The meandric plexus is located between the longitudinal and circular muscles that help in the control of GI motility. And Meissner plexus is the submucosal region that is lies in the submucosa, and its function is to control the GI secretions and other functions. And GIT is also supplied by our autonomic nervous system. Just as I said earlier, it's supplied by the parasympathetic nervous system and the sympathetic nervous system. The parasympathetic nervous system is supplied by the vagus nerve, and the sympathetic nervous system is supplied by the T5 to N2 segment of the spinal cord. Okay. So here you can see the meandric plexus. So this is the GI neurons, meandric GI neurons, and this is the submucosal plexus. And the meandric and submucosal plexus is supplied by the both sympathetic and parasympathetic, sympathetic and parasympathetic nervous system. And there is a sensory neuron that carry information from the epithelium to the higher brain regions. Okay, so this is the anatomy of the how the autonomic nervous system of the central nervous system and the second brain or the enteric nervous system in the GIT interact with each other. So the GIT movement can be of two types. That is infant state and fasting state. Whenever we are not eating any food, that is in the fasting state, there is a motility inside the stomach, and that is called migrating motor complex. And whenever we take the food, it can lead to two types of movement: peristalsis and segmentation. So here is the peristalsis. You can see peristalsis. Segmentation means you can see this blue arrows over here, that is contracting. So whenever it is contracting, it pushes the food forwards, downwards towards the anus, and the peristalsis is also push the food down towards the tube. So this kind of movement, that is okay. This arrow movement is called peristalsis. That is pushing the foot transversely. And this kind of movement, pushing the foot downward towards the anus, is called peristalsis. This movement is called mixing movement. Okay, this is known as mixing movement or the segmentation, and this is the peristaltic movement. Downward movement is the peristaltic movement, and transverse movement is called the segmentation. Okay. So next is the migrating motor complex. The migrating motor complex is that it is stimulated by an enzyme known as motilin. There is an enzyme called hormone known as motilin that binds with motilin receptors in the stomach and in the intestine, that will cause the sweeping of the that is like the sweeper. Like whenever there is a flood happening in a village, and all the all the dirt particles will get into the floor, and there is a sweeper that is sweeping out all the dirt particles from the home to outside. So that kind of movement, that is removing all the dirt particle after a food, is known as migrating motor movement. This migrating motor movement is initiated by the hormone, motilin hormone. Okay. So migrating motor complex is otherwise known as housekeeper of the small intestine. It has got three phases: phase 1, phase 2, and phase 3. So phase 1 means there is electrical activity. But there is no muscular activity. Phase 2 means there is some electrical activity that is very high, that is contracted in nature. That is people. You can see spikes over here. Okay, there is some spike, and this resulting in some contraction. In the phase 3, there is all the waves is having the spike contractions. As a result, there is muscular contraction with all electrical waves. Okay. So these are the different conditions that affect the small intestine. That is, you can see duodenal ulcers. There can be paralytic ileus. There can be small bowel infarcts. And there can be adhesions. There can be disruptions, strictures, muscular diverticulum, inguinal hernia, meconium. These are different pathological conditions that can affect the entire the entire course of the small intestine. And then we got last part is the colon, and you have got an ascending colon, transverse colon, descending colon, and a sigmoid colon. So the ascending colon is then ascending colon then rises from the cecum toward the upper hepatic flexure, and the transverse colon is the colon that comes from the hepatic flexure towards the splenic flexure, and the descending colon is from the splenic flexure towards the rectum or the sigmoid, and sigmoid towards the sigmoid, and sigmoid colon is a colon that extends from the sigmoid towards the rectum. Okay, so the arterial supply, venous supply, and nerve supply to the colon. So the ascending part of the colon is supplied by the superior mesenteric artery, and the transverse colon is supplied by the superior mesenteric artery and inferior mesenteric artery, and descending colon is supplied by the inferior mesenteric artery. Okay. So similarly, it has also got venous supply. The ascending colon is supplied by the ileocolic and right colic veins. Transverse colon is supplied by the mid colic vein, middle colic vein, and descending colon supplied by the left colic veins. Sigmoid colon is drained by the sigmoid veins. Okay. And the colon's function is that it is help in the absorption of the water and electrolytes, and help in producing and absorbing vitamins, and it is also helps in the forming and propelling feces towards the rectum for elimination. So there are the two major diseases that affect the large intestines are ulcerative colitis and Crohn's disease. It is known as inflammatory bowel disease. You should not confuse this with irritable bowel diseases, because there are irritable bowel disease and inflammatory bowel disease. Inflammatory bowel disease of two types: ulcerative colitis and Crohn's disease. Ulcerative colitis affects the large bowels, and Crohn's disease can affect any part of the duct, any part of the colon. Okay. So this features the clinical anatomy and physiology of the gastrointestinal system. Now we can move towards the gut microbiota. Is the students ready, or just the students want a break? What is your opinion?
Based on your convenience, you can continue, sir.
Okay, okay. So can you see the screen?
Visible, sir.
Okay, okay. So now we will move to the gut microbiome. It is the most interesting part of this lecture. So anatomy and physiology you might have learned in your BMS courses, but microbiome is the new revolutionizing concept in the gut gastroenterology. So coming to the gut microbiome, so I will ask you that tell you that gut microbiome, the objective is to study what is the normal microbiome, what is gut-brain axis, and what is the use of probiotics, and how different gut microbes result in the creation of certain different diseases. Okay. So gut microbiome, when it says that we got a lot of trillions of microbes inside our stomach, I mean inside the whole intestine. So we have got there are both beneficial bacteria and harmful bacteria. So the beneficial bacteria comes under this, you can say, column over here, and this box contains two types of phylum, that is phylum Firmiculates and phylum Bacterioids. And there are organisms that comes under Firmicutes, and there are organisms that comes under Bacterioids. And these are the organisms that are responsible for the normal gut, that forms the normal gut microbiota of our human body. All other microbes are very harmful to the human body, that can cause diseases. So whenever there is an increase in certain types of microbes, it can lead to some kind of disease. And whenever there is a decrease of certain kind of microbes, it can lead to certain kind of diseases. So increase in certain microbes and decrease in certain microbes is the problem. So how to treat is that we are still at the research stage. So we are still discovering that there are different types of microbes. So what the practical difficulty is that we cannot get that much of microbes. We have to create that much of microbes in the labs, and it has to be supplemented like in the form of capsules or in the forms of solutions. It has to be supplemented to the general public, and that process is entirely very costly. So most of the people cannot afford the gut microbiome. So gut microbiome, coming to the gut microbiome, there are different. Generally, we are said to have a germ-free microbiome. That is, whenever we are born, the microbes in the stomachs, there will be least number of the microbe before when we are born. So once we are born, the microbes enter into the our GAT, so from the vagina or through the C-section, by the type of the surgery that by the type of delivery we go. So like nowadays, some theory says that even there are gut microbes when we are in the stomach of the mother, because of the microbes that comes from the placenta. Okay, so generally we say we are said to be germ free or microbial free. We have a microbe free gut when we are in utero, when we are in the womb of our mothers. So once we are born, we are exposed to the vagina of the mother, and we get a lot of lactobacilli from the vagina of the mother into our intestine. So if a baby is born by the vaginal birth, he or she will have high amount of lactobacillus. And when the child is born through the C-section, the microbes from the skin will enter into the stomach, into the intestine, and that will cause a high colonization of the clostridium or microbes in the uh, gut. And then when we are less than 1 year, we have got actinobacteria and proteobacteria in the stomach, in the GIT. And during the first year of life, the microbial diversity increases and the microbial composition converges towards an adult-like microbiota profile. So as we grow, as we take the different types, as we grow, our food choices will vary. That we may go into fast food, some may go into vegetarian type of food, some go into mixed type of food. So depending on the food they are taking, and from the source from there taking the food, the microbiota composition will vary from individual to individual. Okay. So around 2.5 years of age, the child will have an adult microbiota that will resemble the adult microbiota. So by the age of 65, the microbial community shift with an increase in bacterioids, phyla, and clostridium inside the intestine. So we have got a like brain interact with the GIT through a top up signaling and bottom up signaling. The top down signaling is that the brain will control the GIT from top towards the down, and bottom up signaling means the GIT will control the brain from bottom to upward. So the GIT inside the microbes inside the GIT can control the functioning of the brain. Okay, that's the function. That is the bottom up signaling. And the brain can respond to the signals that is given by the microbes to the stomach to the GIT by top-down signaling, that is through the vagus nerve. Okay. So we have got two types of stage inside our gut. It can be whenever we have good microbiota, we are said to be in a state of eubiosis. When we have unwanted or unhealthy microbes in our stomach, we say the stomach gut is said to be in dysbiosis. Okay, the eubiosis will provide a protection of intestinal mucosa. It has antagonistic action on the microorganism, and it helps in the maturation and stimulation of the immune system. It helps in the nutrition digestion. It helps in the vitamin synthesis and protein synthesis in eubiosis. But in this biosis, there can be a generation of toxic metabolites like ammonia, and it can also increase the gaseous production. The flatulence will be very high, like we see in irritable bowel disorders and short bowel disorders. And there can be weakening of the immune system, and the immune reactivity will be very high. So in the dysbiotic stage, the patient's health will be in very poor, and eubiotic stage, the patient's health will be very good. Okay, so it depends upon the which type of gut microbes we have in the stomach. Okay, so there is a balance between the eubiosis and dysbiosis, otherwise not symbiosis. Okay, so our symbiosis or eubiosis should be very high than the dysbiosis. So you should have the normal natural gut bacteria in the stomach than the harmful bacteria. So not only the gut is interlinked with the brain, it's also interlinked with the lung. It is also interlinked with the skin. It's also interlinked with the heart. So you got a gut heart axis, you got a gut brain axis, you got a gut lung axis, you got a gut skin axis, and then you have a gut that interact with the metabolism, like obesity. Certain microbes are responsible for obesity, diabetes, and cancer, and certain microbial organisms are responsible for lung cancer, obstructive pulmonary disease, asthma, and pneumonia, and certain like bacterial diseases. Bacteria are responsible for psoriasis. Gut bacteria are responsible for the even actinable virus, that is the pimples in the skin. Okay, and then we have got heart diseases. Uh, certain like microbes are responsible for heart diseases. So, how will you replace the uh, gut microbe? If we got a harmful bacteria in our gut, how will you replace that? So, for that, we have got different procedures. We can use probiotics. Probiotics are the drugs in allopathy. We have probiotic drugs like lactobacillus that we will give for patients who have got diarrheal disease. So whenever there is a diarrhea, there will be washout of the good microbial organism, and the bad microbes will be high. So we prescribe the lactobacillus drugs, and this will deposit the natural bacteria into the gut, and it will prevent the diarrhea, and it will replace the harmful bacteria with the good bacteria. That is probiotics. Then we got engineered microbiome. So that is with the advent of genetics. What genetics has done is that it has created new microbial organism with new genetic ability that can help the human body far more superior than the normal what the normal GAT bacteria can do. So if the GAT, if a normal bacteria can help our body by 50%, genetically engineered natural microbes can help you by like 100%. So we have engineered microbiomes, and then we have got other strategies like normal strategies what anyone can do for their daily routine life. That is diet and lifestyles, avoiding antibiotics, unnecessary use of antibiotics, and like all those conditions can help in the and taking certain vaccinations can help in the formation of the good microbiome. And then we got fecal microbiota transplant. This is an interesting one. That is like we take the feces from a good feces, that is the we take the feces from a good healthy individual from their colon, and we will put inside these feces inside the other persons through the colon through the colonoscopy. Okay, not colonoscopy. We will insert this feces into the stomach, into the GIT of the other persons. That I will give an example. That is, in the study, it has found that whenever we take the feces from the obese people and put into the GIT of the thin people will become obese. And whenever we take the feces from the thin people and put it in the obese people will become thin. So that is known as fecal microbial transplantation. Okay. So then there is probiotics and prebiotics. Probiotics are the live microbes that can be ingested as capsules, and prebiotics are the food, food. You know what are the natural prebiotics? As Ayurveda physicians better than me, so that whenever you give these prebiotics, it will help in the growth of the probiotics. That the healthy or microorganisms inside in the GIT. And then we got immunobiotics. Immunobiotics means often we are not populating the GIT with microbes, but we are populating with suppose for it's a form of vaccination. That is like we will put the killed microorganism into the stomach, into the GIT, and this GIT, what it does is that it will sensitize the immune system towards this microbes. So the immune system will be more efficient in controlling the further whenever live unwanted organisms come, it will be equipped with its immune system to combat that microorganism. It is a form of vaccination, immunobiotics. Then we got postbiotics. Postbiotics means we are not inoculating the GIT with live organisms, but we are inoculating with the spare parts of the microbes, which is not living. We will inoculate with, you can see, short chain fatty acid. We will inanimate microbial cell components, cell-free supranatant enzymes, and exopolysaccharides. These are the non-living things. We will populate the GIT with the non-living organisms. And then we got this is a simple picture of gut brain axis. We'll come into the mental health, how we can control the mental health, different mental health disorders with our diet and by controlling the microbiome. So here are the five most common mental disorders, mental health disorders. You can see anxiety, depression, bipolar disorder, ASD, schizophrenia, etc. So the anxiety is in anxiety, you can see certain microorganisms are high. That is Parvotella, Fusobacteria, bacterioids are high, and Firmicutes are the natural bacteria that is very low in anxiety. In schizophrenia, you can see there is increased Lactinospiraceae, where you don't need to know about these microorganisms in detail. You just only need to know what kind of diet you have to give in these cases once you diagnose whether it is a which type of which type of mental health disorder it is. Then you got autistic spectrum disorder in which actinobacteria, proteobacteria is high, and you have got bipolar disorder in which Clostridium and Colonia is high, and you got depression in which Klebsiella streptococcus is high. So these are the different microorganisms that is high and low in different mental health conditions. So we will give this kind of this kind of food for this kind of disease. For schizophrenia, we will give spices, food rich in spices. We have to give food rich in spices and medicinal herbs and dairy products. For the people with anxiety, you have to give drugs, that is, fruits and vegetables should be high, and medicinal herbs should be high in anxiety. And then you have got depression. Sorry. Depression in which you have to give prebiotics and postbiotics and dairy products. So this can alleviate the symptoms of depression. Okay. And then for autistic, you have probiotics. You can give probiotics. So these are the different conditions in which you have to choose different what kind of food products for the patient. And then we got microbiome and diabetes. So what happens is in diabetes is that there will be unwanted growth of the unwanted microorganisms like beta proteobacteria, brevibacterium. All these things will be increased, and the healthy microbes like lactobacillus, bifidobacterium, Fusobacteria will be low. So this will lead to gut microbial dysbiosis. It will lead to increase in lipopolysaccharide elevation. That will lead to inflammation, insulin resistance, and lead to diabetes mellitus. So what we have to do is that we have to supplement with the probiotics. We will get the lactobacillus bifidobacterium capsules in allopathy stores. We will get this. I don't know whether it's available in Ayurvedic, but this kind of bacterial supplementation is very essentially good for preventing the type 2 diabetes. And we have got plant material rich diet and animal rich diet food. So in diabetes, we have to ask the patient to adopt a plant-based diet, and that is a fiber-based diet, and avoid fat or protein-rich diet. So whenever the plant-rich diet food is taken, the natural bacteria like bacterioids are elevated. It will increase the short-chain fatty acid, anabolic enzymes, and butyrate, propionate, and acetate, and it will help in increasing the insulin sensitivity. As a result, the glucose level will be controlled. If you take an animal-based diet, the unwanted bacteria like Firmicutes will be high. It will decrease the short-chain fatty acid, and it will cause an increased insulin resistance, and the glucose will not be properly controlled. Okay, so we often say that the patient have to do exercise for the diabetes. But the point is that if you don't have the right gut microbiota and you're doing exercise, you will not get the right result. So if you are implanting the gut microbiota with the proper microbiome and then asking the patient to do exercise, it can lead to good health outcomes. So that is the thing. You can see the short-chain fatty acids and GABA and these branched amino acids are less. Short-chain fatty acids are high in people who responded to exercise, who had a good microbiome, and people who responded poorly to exercise had a bad microbiome. And coming to the microbiome and liver disease. Okay, so here you can see the different diseases. Here you can see primary sclerosing cholangitis. In this primary sclerosing one, there is a condition in which there is dysbiosis. And then you can see hepatocellular carcinoma. In hepatocellular carcinoma, you can see there is a dysbiosis, and it is due to increased Listeria E. coli levels. And in liver cirrhosis, that can be seen in alcoholics, also have dysbiosis. And primary biliary cirrhosis also have dysbiosis. And all other hepatitis and other conditions can have unwanted growth of the unwanted microorganisms that causes the disease and disorder. And this is the alcoholic liver disease. You can see this is non-alcoholic liver disease or the fatty liver. This is primary biliary cirrhosis. So all these conditions, when you check, you can see that the lipopolysaccharides are elevated. Lipopolysaccharides are harmful chemicals that are produced by the harmful bacteria inside the gut. Okay. So we have to replace all these harmful bacteria with the good bacteria, that is the good probiotic capsules. And then here you have got microbiome and relationship between the microbiome and cardiovascular disease. So the interesting thing is that the gut microbiome reactivity with the brain can vary depending upon the sex in humans. So for hypertension, in case of hypertension, you can see that the lactobacilli is less. But in women, the hypertension is caused by increased lactobacilli. So in women, you have to decrease the lactobacilli. In the male, you have to increase the lactobacilli. So for obesity, also you can see the difference in the microbial composition in male and female. And similarly, you can see the impaired glucose tolerance in males and females. So all these things, dyslipidemia also, you can see that there's a difference between how the microbiome reacts with the cardiac disorders. So when we go for treatment, we have got prebiotics and probiotics. Okay, probiotics are the capsules that we get for eating, and probiotics for consumption, and prebiotics are the plant-based diet that helps in the growth of the probiotics. So cardiovascular disease can be controlled by prebiotics, and probiotics. Okay, so these are the different. So probiotics can have antioxidant property, have antiplatelet property, and got anti-inflammatory properties. And prebiotics can also decrease the levels of the cholesterol. That is, the plant-based diet can decrease the levels of the cholesterol. And then you got microbiome and allergy, and you can see in asthma. Children with asthma, they have high levels of bacteriotes and low levels of healthy bacterium like bifidobacterium and Veillonella. These are Veillonella are the healthy microbes, so that is low, and harmful bacteriotes are very high in children with asthma. So in asthmatic people, the people will have food allergy, they can have atopic dermatitis, and they can have asthma. So here you can see the asthma, Streptococcus, Haemophilus, Moraxella, all these are very high in the lung microbiome. That is, even the lungs also have microbes in the lung. So that is called lung microbiome. And there is gut microbiome, healthy gut bifidobacterium and Physiobacterium is levels are low in gut microbiome. That this lead to this asthma. And food allergy, you can see the gut microbiome, these microorganisms, Lactobacillus spiraceae, Romano-Coccacia are high. This will cause food allergy, and low levels of enterobacteria and bifidobacteria will cause food allergy. And atopic dermatitis means inflammation of the skin. It can be caused with the elevation of Staphylococcus aureus and decreased level of the Staphylococcus coagulans negative suppurativa. So coming to the microbiome and skin, so these are the different conditions in which you have different associated with the skin microbiota. So different skin microbes can cause different types of skin diseases. And there's coming to microbial and gut GIT. So the normal esophagus will have Streptococcus, Klebsiella, and Eubacterium, Helicobacterium, E. coli, Haemophilus, etc. But whenever there is a gastroesophageal reflux disease that we studied in the clinical anatomy and physiology, there will be increased level of Pasteurella, Haemophilus, and Fusobacteria. This will causes the GERD. It's a response in some way linked into the generation of the GERD. And then we got Barrett esophagus. Barrett esophagus is a pre-malignant condition in which there is a pre-malignant condition. And that pre-malignant condition of the esophagus is caused due to certain bacteria and that is listed over here. And then you got eosinophilic esophagitis, that is due to allergic esophagus. Whenever there is high levels of eosinophil in the esophagus, it is called eosinophilic esophagitis. It is caused due to the elevated number of the Corynebacterium and the Neisseria. And then you have got esophageal cancer. It is caused due to the high levels of Neisseria, Haemophilus, etc. So these microorganisms, high levels of certain microorganisms and low level of beneficial microorganisms is responsible for certain diseases in the GIT. And coming to the irritable bowel syndrome is a psychosomatic disorder in which the patient will have abdominal pain, flatulence, and tiredness, etc. It is caused due to the increase in firmiculates to bacteroides ratio and decrease in some firmiculates families. It is these microorganisms are responsible for the irritable bowel syndrome. And then we discussed about the ulcerative colitis and Crohn's disease in the clinical anatomical part. And that is the ulcerative colitis and Crohn's disease. Ulcerative colitis is caused due to the decrease in the butyrate producing bacteria, that is Escherichia coli and Physiology bacterium. And the Crohn's disease patient is due to the decreased level of the Dallister invasions. And then we got celiac diseases. And celiac diseases the celiac diseases is due to it's a type of allergy to food, especially to the gluten allergy. So that is caused due to the presence of certain bacteria that is very less, like bifidobacterium longus, Clostridium histolyticum. These organisms are very less in the celiac disease that is responsible for the generation of the celiac diseases. And for colorectal cancer, so there are certain strains like Bacteroides and Enterococcus and Escherichia coli and Klebsiella that is responsible for the colorectal cancer, etc. So these are the different conditions. So the conditions in the human body, whether responsible, whether we get certain conditions because of certain microorganisms. So in general, I will sum up and give a simple idea that we need a healthy gut microbiota for the proper functioning of our body, and that is called eubiosis. And we need, and if the eubiosis is compromised by unhealthy microorganisms, it will lead to dysbiosis. So certain conditions are caused due to growth of unwanted microorganisms and decrease in the unwanted organisms. And what we have to do is that we have to supplement those organisms. We have to identify which disorder have which all microorganism and which all microorganism can be supplemented by the probiotics and prebiotics. So we have to arrange a plan, a treatment diet plan, which can alleviate the problem by giving probiotics, prebiotics, postbiotics, and psychobiotics. I hope you have understood, and this is in some the how we will manage the gut microbiota for each and other disorders. Thank you. This finishes the topic. Madam, you are there?
Hello, yes, sir.
Okay, I finished the topic.
Okay, sir. Thank you so much for elaborately explaining regarding the anatomy, physiology, and also the clinical aspect of the digestive system, and also regarding the gut microbiome. I hope our participants have also enjoyed the session. Now I request all the participants to kindly leave their questions in the chat box. You may also unmute yourself and ask questions directly to sir. Also, I request the participants to leave their feedback in the chat box. One of the participants is asking, will they be getting the PDF of the slides?
Okay, I will send the I will send the PDF, send the PPT to Jason, and you will share with me.
Okay. Thank you, sir. Okay. Graph of stomach is new concept for me, says Dr. Nalini.
Yeah, there is a just like the SN node in the heart, we have got pacemaker cells in the GIT, and that is called interstitial cells of Kegel. So whenever there is an activation of the interstitial cells of Kegel, there will be an electrical activity, and this electrical activity will lead to muscular contraction of the stomach, and this muscular contraction will help in the movement of the crunching and movement of the food.
Thank you, sir. Any more questions from the participants?
Okay, so one of them is asking for lactose intolerance. Like lactose intolerance can be the it is not the problem of the milk that we are getting the lactose intolerance. There are certain components in the milk that can make some people allergic to that milk itself. It is due to the intrinsic property. This is due to the genetical problem. Some people will have lactose intolerance. So we need a lactase enzyme inside the GIT to digest the lactose inside the stomach. So some people will have abnormal genetic condition or decreased production of the lactase enzymes inside the human in the gut. So such people, whenever they take this food, it will not be properly digested and it can cause allergic reactions. So it's due to the enzyme deficiency or due to the genetic problem and can be also due to epigenetic problems.
Hope your question has been answered, Ashita. Any more questions? Drugs name for prebiotic, probiotic, and postbiotic. Madhuri Rai is asking so.
Yeah, like in for direct diseases, we have got Visilac, VIZYLAC. So Visilac capsules are available in the pharmacy, in the pharmacies. So you can prescribe the Visilac for people who have diarrhea, who have got diarrhea. You can prescribe the Visilac to replace the abnormal microbes with good microbes. So this Visilac. And then we have got endogerminoma, but it is very costly. It is available as solutions, but it is very costly. But most affordable for patient is Visilac capsules.
Thank you, sir. Hope the question has been answered. Dr. Sumi is asking, thank you very much, sir. Very useful class. So there's a doubt regarding Ayurvedic view, how we can identify which bacteria is harmful for patient, and through Virechana, how much we get sure about elimination of that particular harmful bacteria.
Okay. The thing is that it is still in allopathy. It is a new field, and it is not most of the students in MBBS or in even the MD doesn't have better idea about the gut microbiota, except in physiology, microbiology, and gastroenterology. These specialties in the allopathy medicines have some exposure to the gut microbiota field. So mostly it is mostly the gastroenterologists are available are aware about the gut microbiome. So it is not possible to at the current stage it is not possible to take the what we actually do is that in the lab we will take the feces and we will after taking the feces we will send for a culture and we will identify which organism is more and which organism is less. That's how we will do. And if the organism, and then we have to check which is the harmful organism that is high and which is the harmful organism that is less. This is a laboratory process that is done only for research purpose. For clinical purpose, there is no currently any guideline that has been formulated to treat the certain disorder based on the gut microbiome because it is still in the infancy stage. So I would suggest better to do as an Ayurveda physician to do the diet control to recommend plant-based diet and to give Visilac capsules or probiotic capsules, and that would be the and adopt some certain lifestyle changes like adopting certain avoiding fast food and adopting plant-based diet. These are the best things that you can do. And but in general, try to increase the levels of the good microbiomes, and it is very hard to eliminate the abnormal gut microbiome because each microbiome is sensitive to different types of antibiotics. So we need certain types of antibiotic to kill certain organisms. But the problem is that whenever we give the antibiotics, it can also kill the natural microbiome as well. So and using antibiotic as a treatment for killing the unwanted microbes is not a good idea. So we generally recommend to increase the levels of the good microbiomes by probiotic capsules and prebiotic supplementations.
Thank you, sir. Can we deal it with probiotics? Ashita Arun is asking.
Yeah, we can deal it with probiotics. We can give both probiotics and prebiotics. Prebiotic diet like yogurt and plant-based diets, and we can give probiotic capsules. You can recommend it for patients. It is very good.
Okay, sir. Does frequent deworming in children cause loss of probiotics or loss of, I think, gut microbiome, she meant?
Frequent deworming, not only like deworming, deworming these things, but also antibiotics. Use of antibiotics can also can lead to loss of the normal gut microbiome. One of the condition there is known as necrotizing enterocolitis. Necrotizing enterocolitis is a condition in which whenever the person is taking clindamycin, an antibiotic, for 14 days, what will happen is that it will kill all the microbes, healthy microbes inside the gut. And when all the healthy microbes are destroyed, what happens is that the faulty microorganisms, unhealthy microorganisms start to grow, and it will start to again worsen the condition. So to prevent that, after giving this giving the clindamycin, we give the supplement with the good microbiome also. So even if the bad microbes are killed, we will compensate that with good microbiomes. So deworming, frequent deworming, and I'm not sure how much the deworming antibiotics can kill, make successful impact, but I know that there are certain drugs like clindamycins, certain drugs like moxidectin, all these things can affect the GI microbiome. So we have to, whenever you give an antibiotic, you have to supplement it always with the gut with probiotics.
Thank you, sir. Any further doubts from the participants? Also, I request the participants to kindly give your feedback regarding the first session of Dahana. Any further questions? Okay, there's one more question, sir. As seeing the influence of microbiota in every system, it feels that whatever case may be, initial line of treatment should be just one Deepana, Pachana, and Shodhana. Is it correct thinking, sir?
I'm not familiar with.
Yes. So, yeah, the Ayurvedic questions will be further answered in the upcoming sessions. Sir is from MBBS background. So, anything related with physiology, anatomy, and clinical anatomy, also the gut microbiome, the questions can be asked. Okay, can antibiotics cause problems or loss of microbiome? Yes, sir. Just yeah.
Definitely cause loss of microbiome because antibiotics it is a chemical substance. It doesn't have a it is not an AI system that can selectively kill unhealthy microorganism and save spare the life of unhealthy organism. There is no certain form of intelligence in antibiotics. It kills both healthy and unhealthy alike. So it is the complication of the one of the drawbacks of the antibiotic. So to prevent that drawback, we will supply it. We will give probiotics in whenever we give the antibiotic. That should be the ideal practice. But it is generally less followed. But in allopathy, the doctors are concerned whenever it comes to GI cases, they will give the probiotics whenever give the antibiotics. But in case of respiratory disease and all, they will never give they never give prescribe the probiotics with the antibiotics, even though we have to prescribe the probiotics.
Thank you, sir. Any more questions from the participants?
Thank you, Dr. Fahad. And I have one doubt, means clarity regarding the fecal transplantation. You all said that is an amazing concept. So if flora is loose, means we can transplant a new healthy flora, no? so that we can avoid the diseases, is it?
Yes, yes. So fecal microbiota transplantation is an excellent idea, because what they found is that whenever we take the feces from obese people and put inside of thin people will become obese. And when we take the fecal matter from thin people and put it inside the fat people, they become thin. So the gut microbiota plays a big role. It interacts with the brain, it interacts with the lungs, it interacts with the skin, it interacts with the liver, it interacts with the major organs of the human body. It has got a metabolic role also. So whenever there, uh, there are certain species of the microbiomes that makes us thin, and there are certain species of microorganisms that make us fat also. Apart from the other genetic causes, I'm not saying this is the entire solution. This is a part of solution, because there are also genetics inside the human cells also play a role in whether becoming a person is fat or weak. But if the obesity is caused due to epigenetic causes, definitely it can be resolved with the gut fecal microbiome transplantation.
Thank
Yeah.
you, sir. Okay.
So
There are two more questions in the chat box. So, when to use probiotics and prebiotics? Dr. Sabira is asking.
So, there is no hard and fast rule to when to use probiotics and prebiotics. You can use as a preventive part, and it can also use as a therapeutic part. So, preventing part is that you can incorporate the probiotic and prebiotic. You can use the prebiotic more than the probiotic in the preventive part, because already there is healthy microorganisms. So you only need to feed that microorganism using prebiotics like yogurt, etc. And if you are going for a therapeutic part, if you are going for treatment, for example, for you got a diarrheal disease, you are using antibiotics. So at that time, you have to write probiotics itself, because antibiotics can kill the normal microbiome. So you have to prescribe the probiotics. And also, you can simply give probiotics. You can also supplement yourself with simply probiotics. Normally, it is also very healthy.
Thank you, sir. One more question. Is loss of appetite and loss of gut microbiome interrelated?
Loss of
Appetite and loss of gut microbiome, is it
Okay.
interrelated?
Yeah, there is a certain microorganism can make your GIT upset. It can lead to dysbiosis. Whenever it is lead to dysbiosis, it can make you either unhealthy. It can either make you crave for unhealthy food, and or can also make you it can also make you what is apathetic. So we don't know which organism cause which. So it depends upon it is influenced by a lot of factors, like by the host genetics. It is also influenced by the other conditions. So there are certain conditions in which you will have decreased interest in food. So that can be caused due to psychiatric disorders, it can be caused due to metabolic disorders, etc. And apart from that, these microorganisms also have certain rules. So that's how we can say. We cannot say that only the JT microbiome is the entire cause for the anorexia, or whether due to increased craving of food.
Thank you, sir. Next question. For a diabetic patient, when diet given in terms of reduced amount of carbs, will it affect microbiome? What can be done for that?
Yeah, you can ask the patient, you can supplement such patients with probiotics. If you're even though if you're restricting the diet, you can opt for plant-based diet. Plant-based diet is good for diabetics, and together with that, you have to give probiotics also. So that will compensate for the cutout of the carbohydrate that we do.
One patient having severe mouth ulcers after intake of 2 courses of antibiotics, which is prescribed by dentist, what type of diet or probiotics we can suggest to her?
So, if a person develop mouth ulcers after taking the antibiotic, it doesn't mean it is due to the microbiotic problem. It is due to the drug allergy reaction. That is an immunological response to the drug. So that immunological response will create ulcers, mouth ulcers in the stomach, in the mouth. That is known as Steven Johnson syndrome, SJS. Steven Johnson syndrome. So that has nothing to do with the GI microbiome. It is purely an immunological reaction to the gut, to the antibiotics that has been prescribed. So what we have to do is that we have to stop that antibiotics.
Hope your question has been answered. Any more questions from the participants? Any further questions? Not, we will wind up our session for today.
Dr. Akshada, can we have the feedbacks?
Yes. Participants, kindly give your feedback. Also, you can unmute yourself and talk about how you felt about today's session. Your feedback is very important for us, for the further upcoming sessions and also for our speaker. So kindly give your feedback regarding how you felt. So there are a lot of doctors who've been telling it's a very informative session, and thank you for clearing the doubts. So if any few of the participants, okay. Dr. Sumi is saying very complicated topic explained in a very clear and simple way. Thank you so much, sir. Okay, there are two more questions, or maybe, yeah, one question. Is colon cancer and rectal cancer affected by the gut microbiome?
Yes, there are, whenever we talk about cancer, we have to discuss about the host. There are host and what we call this a symbiote. Our microorganism is a symbiote. Just like what you see in the movie Venom, you got the Venom is a symbiote that thrive on Tom Hardy. So, like Tom Hardy for us is like our GIT, our genetics and epigenetical environment, and the venom inside is just like that of gut microbiota. So there are factors in the host, like genetic disorders in the genetic disorders in the person, of the cells of the person, that can lead to that can lead to colonic and cancer or rectal carcinoma. And at the same time, there are also mutations in the mutations in the microbiome, or unwanted growth of the unwanted microbiomes, that can lead to the formation of the cancer. So it is a two thing. There can be problem in the host, and there can be also problem in the symbiote. So both of them can lead to the formation of this cancer.
Thank you, sir. Dr. Fareen Banu is telling it was a very wonderful session. Thank you so much for patiently answering all the questions. Okay. One last time, any questions from the participants? I think we can wind up our today's session. Thank you so much. Dr. Jasul, would you like to add or tell something?
Yes, thank you. Thank you so much, Dr. Fahad. And Dr. Fahad is my friend actually, and we know each other for the last 10 years, and he's very keen in observing all these things, and in the researchers in the new era of epigenetics, and he's also the good author, and he wrote so many books also. So thank you so much, Dr. Fahad, for insightful session. And in 1 hour, you just completed the entire GIT anatomy and physiology very nicely, and also the innovative topic on the gut microbiota also. Thank you so much for coming and having this session. Oh, okay, over to you, Dr. Akshada.
Thank you, Dr. Jasul. Once again, I would like to thank Dr. Fahad for today's session, for spending time with us and very nicely explaining about the topics, also patiently answering all the questions. Thank you so much on behalf of Ayurveda MAP and on behalf of all the participants, sir. Thank you, and thank you to all the participants. See you all in the next session of Dahana. So until then, signing off. Thank you so much.
Next session on tomorrow also, and we'll be sharing the free link of tomorrow also. Okay. So see you tomorrow. Okay. Thank you.
Good night.